All right, everyone, welcome. Today we're going to do something really practical. We're going to walk through the pharmacological management of gout using a case study. This way, we can really connect the dots between the pathophysiology you've been learning and the actual clinical decisions you'll have to make.
So here's how we'll tackle this. First, we'll meet our patient, TJ. Then we'll figure out what's going on, treat his acute flare, and then talk about long-term management. Finally, we'll tie it all together in his care plan. Pretty straightforward.
All right, let's jump right in. First up, let's meet our patient, TJ. He's a professor, and he's come in with a really classic and really painful presentation. So this is what TJ is dealing with. It's a classic acute gout flare in the big toe, which we call podagra. I mean, just look at that swelling and erythema. You have to understand, for the patient, this is not a minor ache. This is an absolutely excruciating, debilitating level of pain. Okay, so here's TJ's chart in a nutshell. He's 58, a professor. Now, this is important. He's had 3 flares in the last year. 3. That's a huge red flag. He's also got hypertension and obesity, which are common. But look at his med list. Amlodipine, fine. But that hydrochlorothiazide, or HCTZ, I want you to file that away. It's a major piece of this puzzle, and we'll come back to why it's so important. So we have our patient. Now let's play detective. What's actually causing this? We need to dig into the root cause of these recurring attacks. And boom, here's our smoking gun. His serum urate is 7.5 milligrams per DL. Now, you should remember from your biochem that the saturation point for urate in the blood is right around 6.8. So at 7.5, his blood is literally super saturated with this stuff. It's like having sugar that won't dissolve in your iced tea. It's just got nowhere to go but to precipitate out as these nasty, sharp crystals in his joints. So why is his urate so high? Well, there are a few things going on. His diet isn't helping. Lots of red meat, shrimp, sodas. He drinks beer every day. And we know obesity is a risk factor. But remember that medication I told you to file away? The hydrochlorothiazide? From a pharmacology perspective, this is a huge deal. Thiazide diuretics work in the kidney, right? Well, they also compete for excretion with uric acid, which means less uric acid gets out of the body. It's a major, major contributor here. Okay, so TJ is in your office. He can barely walk. This is our first big decision point. What are we going to do for this acute pain? We have to be effective, but even more importantly, we have to be safe. The ACR guidelines give us 3 main tools in our toolbox for an acute flare: NSAIDs, glucocorticoids, and colchicine. All of them work, but, and this is a big but, they are absolutely not interchangeable.
And this is where you earn your stripes as a clinician. You don't just pick one at random. You have to look at the whole patient. So thinking about TJ, with his hypertension and his current meds, which of these 3 is the safest and most effective choice? What do you think?
All right, let's walk through the thought process here. Let's start with NSAIDs. A high dose, which he'd need, can actually make his hypertension worse and mess with his blood pressure meds, so probably not a great choice. What about glucocorticoids, like prednisone? Well, they can cause fluid retention and, you guessed it, also raise his blood pressure. So both of our first 2 options have some serious downsides for TJ. That leaves us with colchicine. It's an anti-inflammatory that works beautifully for gout, but it doesn't have those same effects on blood pressure. So for this specific patient, colchicine is hands down the safest and best option.
Okay, so we've put out the fire. His acute flare is under control. Now we have to shift our thinking to the long game. How do we stop this from ever happening again? That means tackling the root problem, his high uric acid.
The way we manage this now is with what's called a treat-to-target strategy. This is a really important concept. The goal isn't just to make the patient feel better today. The goal is to get their serum urate level down below 6.0 milligrams per deciliter and keep it there. Why 6.0? Because below that number, the urate crystals that are already hiding out in his joints will actually start to dissolve. We're not just preventing new fires, we're cleaning up the fuel. And our go-to drug for this, our first-line urate-lowering therapy, is allopurinol. But how you start it is absolutely critical. The mantra is start low, go slow. You'll begin with a low dose, maybe 100 milligrams a day, and then check his levels and slowly increase the dose every few weeks. Now, why do we do this? It sounds counterintuitive, but if you drop the serum urate too fast, you can actually shake loose some of those existing crystals and trigger another painful flare. So slow and steady wins the race here. But look, we can't just throw a pill at the problem and call it a day. Great gout management means taking an integrated approach. We have to look at the whole clinical picture. And this brings us back to his med list. That HCTZ has got to go. So, a key move here is to talk with his primary care doc about switching his antihypertensive. And there's a really elegant option, losartan. Think about this. It's brilliant. We're taking away a drug that raises his uric acid and swapping it for one that not only controls blood pressure but also has a uricosuric effect. That means it actively helps the kidneys push more uric acid out of the body. You're treating two problems with one medication. It's a fantastic move.
And of course, we have to talk about lifestyle. But this can't be just vague, eat better advice. It has to be specific and targeted. We're talking about high-yield changes, like let's swap the daily beer and soda for water, let's cut back on the red meat and shellfish. These aren't just suggestions. They are crucial therapies that work alongside the medications to get him to his goal. Okay, so let's bring this all home. We've gone from presentation to diagnosis to treatment options. Let's lay out the complete, comprehensive care plan for TJ. And here it is. It's a 3-pillar plan. Pillar 1, treat the acute flare. And for him, that's with colchicine. Pillar 2, start chronic urate-lowering therapy, allopurinol, with that start low, go slow approach, and a target of less than 6.0. And Pillar 3, optimize everything else. That means swapping the HCTZ for losartan and making those key lifestyle changes. This is what good, personalized gout management is all about. So we have this beautiful evidence-based plan. It's perfect on paper. But in the real world, we run into a huge problem. And that problem is adherence. The data is clear. Adherence to gout medications is terrible, one of the worst for any chronic condition. Why? Because once the excruciating pain is gone, patients feel fine and they stop taking the daily pill. They don't always grasp that this is a lifelong therapy to prevent silent damage. And that leaves us with a final and maybe the most important question. The science is clear. The pharmacology is elegant. We know what to do for patients like TJ. But our biggest hurdle isn't the what, it's the how. How do we bridge that gap between our perfect plan and the patient's reality? How do we use education, build trust, and create a partnership to make sure the plan actually works? I want you to think about that, because that's a central challenge you will face in your own practice.